is Elisa. I'm a family nurse practitioner. I currently work at a facility, Cabrini, for the uninsured. I have a passion for working for the uninsured, the homeless, the underserved. Because when you look at patients, when they go into the emergency room, those are the places that they have to go for acute care. And they don't really offer health promotion or health prevention there. So when my first clinical experience as a nurse practitioner, when I was in my clinical, I went to the Detroit Rescue Mission, and that was my first experience with this population. And we did health physicals for all the men there. And with them, we had to do a prostate cancer screening as well. Well, I was sort of sad about the African American men there was unaware of what prostate cancer was, prostate cancer screening, what a prostate was, where it was located, and they had no idea that they were at high risk. So with that, I started to focus my interest on methods that I may be able to do to help educate African American men to get it out about the prostate cancer and prostate cancer screening. So with that evolved my capstone project, which is an educational intervention for African American men and their significant partner about prostate cancer and prostate cancer screening. So when we look at prostate cancer is the second leading cause of cancer death in all men. It also affects men aged 45 to 70 who are in the highest risk. But if they have a family history, a father, or uncle, or brother, that's going to put them at an even greater risk. The American Cancer Society has estimated that over 238,000 men were diagnosed with new prostate cancers. And they also estimated that over 29,000 men died of prostate cancer. So when we look at the African American men, the mortality rate is 2 times higher among that race than any other race. Oops. Sorry. So despite these high mortality rates and the statistics, African American men have a lack of participation in prostate cancer screening. Well, when we look at prostate cancer screening, we look at the 2 exams that are done is a digital rectal exam and also a blood test, which is the PSA. These 2 exams should begin with a discussion, preferably with a healthcare provider. Healthcare providers' care and practice is usually guided by national guidelines. The national guidelines are recommendations that are normally evidence-based and also look at the harm and benefit of the services being provided. When we look at the American Cancer Society, they recommend that men age 50, which is the average risk, to be screened. When we look at a higher risk, when we talked about if they have a father, a brother, or uncle, that will put them at a higher risk, then that screening should begin at age 45. However, the United States Preventive Task Force, which is another recommending organization, do not support routine screening at any age. These recommendations are based on screening trials. There were 2 large screening trials done in the 1990s, and they were done over a 7 to 8 year period, looking at the mortality rate with prostate cancer, if it would make the difference. There were 2 studies. One was the European Random Study Prostate Cancer, and there was also the prostate, lung, colon, and ovarian. When we look at the European study, they did a study back then that showed a 20% reduction in mortality rates, and with the 11-year follow-up, it supported it with a 21% mortality rate reduction. But the PLCO did not find any difference in the mortality rates of their study. But when we look at the demographic population of the PLCO, we see 86.2 non-Hispanic whites. But when we look at the non-Hispanic whites, it was less than 5%. So although we are guided by, of course, we want to do the best practice for our patients, we also have to look at the individual, we have to look at the situation that's involved, we have to look at the facts. And the fact is that African American men get prostate cancer 2 times more than any other race, and they die 2 times more. Also, we look at the statistics. We see that in 2000 and 2004, we see the incident and death rates for African American men are much higher. So, as I went through and did an extensive literature review to see why there's such a lack of participation amongst the African American men, there were a few factors that were identified. So as I looked through quantitative and qualitative research studies, and they did some focus studies where they interviewed the men, and they also did studies. One of the factors is access to care. That would cause a low screening rate if you have no employment or low employment, a lack of economic resources. Also, if you are uninsured, you don't have the means of getting the services. And if you have limited local resources for care, you may not have a computer, or you may not have to know where the free clinics are. You may not know where they provide these services. And also, when we look at inequities to care, we're looking at disparities, social disparities, economic disparities as well. Mistrust, that is something that we have to look at, because there has been a history with African American and research showing that these are just two studies, but there have been several studies that have shown where the care they were misled on what the care actually was, what the research study was about, excuse me. So one of those being the Tuskegee syphilis study. There were 400 African American men who had the late stage syphilis, were not treated, thought they were being treated, and 107 men died. We also have to look at another study that was done in Baltimore, Maryland, where there were 7,000 young men who were tested for anemia, told they were tested for anemia. They did not get parental consent from these young men. And actually, they were looking for extra Y chromosome, because it was the assumption that if there was an extra Y chromosome, that gave criminal tendencies. So these young men were labeled as criminals. Oops, I'm sorry, I keep doing that. The shared decision-making process should be something that is done between the healthcare provider and the patient and the man. And if they're misinformed or uninformed, of course there won't be any training. If there's a lack of communication with healthcare providers, if they're not talking with them and discussing and making the decisions for them instead of with them, a lack of knowledge to make informed decisions about prostate cancer screening would definitely decrease participation. When we talk about the lack of communication, there's also a lack of communication with family and friends. One of the focus studies did identify that men said that's not something you talk about. It's private, it's a private conversation. And then there's that fear of dying or finding out that you have prostate cancer. And the screening itself, the digital rectal exam in particular, is scary for some men. And then we have culture and we have the stigmas of not thinking that if you're not sick, you don't have to go to the doctor. And the stigma, again, of the digital rectal exam, equating it with homosexuality. So when we look at the social support in the literature, it did show that social support did have a positive impact. That if they had someone there to discuss that with and to go through that with them, then it's a more possibility that they will have prostate cancer screening. There are limited studies showing African American men and their partners, and there also were limited studies between the man and the woman in general for female participation. So with that, the gap in the literature showed the limited studies, but it also showed that significant females would have a significant impact if they discussed and encouraged men to participate in prostate cancer screening. So the aims of my study is to evaluate African American men's knowledge of prostate cancer and prostate cancer screening, and also looking at the impact of an educational intervention and the intent to get screened. Also, I wanted to evaluate the effect of prostate cancer screening knowledge in the women and their subsequent intent to encourage the men to participate in prostate cancer screening, or at least have the discussion. The research questions are, the first one, as you can see, to what extent do men and women's knowledge of prostate cancer increase from the beginning of the study to post-intervention? To what extent do men and women's attitude toward prostate cancer change from beginning the study to post-intervention? And to what extent do men and women differ on their pre-survey knowledge and attitudes regarding prostate cancer? And to what extent do men and women differ on their post-survey knowledge and attitudes regarding prostate cancer? So the theoretical framework that was used for my study that I found relevant was the health belief model, because it does explain and predict behaviors, and it also focuses on attitudes. And we look at the perceptions and the probability of action, which is what the health belief model is that if a person can perceive that they are susceptible to a disease, then they will recognize the vulnerability along with perceived severity and benefits and threat, then that would motivate them to want to do something for themselves. And then to provide self-efficacy by equipping them or empowering them can give them that confidence to take the action. When we look at the health belief model on a schematic diagram, we're going to take a look at, here is where we want it to end up with increased prostate cancer screening, an increase to intent to screen, and also to have that discussion with the healthcare provider. Well, after I submitted my proposal, I did get IRB approval. I did do an amendment to add 2 additional churches, but in the end I had 3 churches in the metropolitan Detroit area that we just conducted the study. I obtained permission from each church pastor, and then I had to do informational flyers to place into all the churches, in the bulletins and in the program, so that they would, and with the sign-up sheet. So we also gave $5 gift cards. A lot of money. I love it. So the inclusion criteria, of course, for the male participants, African American men, 40 to 70 years of age, and for the female participants, we wanted them 18 years of age or older. The only exclusion criteria is if they had a history of prostate cancer, then they could not participate. And we did have one gentleman that said that he had it, and we had to eliminate him from the study. So the participants, my convenience sample, I had 19 men and 19 women. The men were a mean age of 55.3, and they were all African American, self-identified. And for the women, we had 18 African American and 1 Caucasian, and the mean age for them was 53.1. They were all college, well, they weren't all, but they all had some college education. The men had 12 men that had college education and 7 with high school. And with the women, there were 16 college educated, 1 high school, and 2 had grade school education. The tools and data that was used, we used a 5-point Likert scale for the surveys. We used the paired t-test to determine the differences in the variables, and the variables for the independent variable was the educational intervention, and the dependent variable was the knowledge and the intent to participate on prostate cancer screening. We used a quasi-experimental design to measure the outcomes of the non-randomized participants, and we used the demographic data forms. We had a pre- and post-survey that was specific for each gender. The surveys were piloted prior to the study, and we also used an educational PowerPoint for the presentation for the prostate cancer and prostate cancer screening. We obtained informed consent and had them to complete demographics. We then gave them a pre-survey assessment which measured knowledge, behavior, and attitude towards prostate cancer and prostate cancer screening intent. And then those were collected. We had an educational intervention where I talked about I defined the prostate. I did the anatomy and so they would know where the location was for the prostate. We also talked about the prostate exam, the digital rectal exam, and the PSA, the blood test. And we talked about the statistics that we talked about earlier of the disease mortality. We also talked about the national guidelines for the prostate cancer screening. Then we had a discussion and question session. Once that was done, we did a post-survey assessment, which was the same identical questions to measure the same variables that we talked about earlier. So each session was 1 day, and we did 3 different ones for the 3 different churches. And these are the findings. The t-test showed that for the knowledge change, as you can see, the men, the mean was 5.95 pre-survey and post-survey 8.53. And the standard deviation 2.17 and 2.38, and that gave us a significant p-value of 0.001, less than 0.001. For the women, you can see that the mean pre-survey was 6.89, and the post was 8.05, with the standard deviations of 3.14 and 2.37, and the p-value there was 0.124, which showed us that the women were knowledgeable prior to the educational intervention. But the good thing is that the men did increase in their knowledge post-intervention. So that made me happy. And then we looked at the change in attitudes, which showed that pre-survey 3.81, and this is for the men, and post-survey 4.14. We did have an increase with the p-value of the 0.030, and for the women it was 4.19 and 4.50 post-survey, and it still was an increase. So the female survey, I just wanted to put up some of the questions here, but just to give you an idea, as you can see, there were 89.5 and also 94.1 that heard about prostate cancer and heard about prostate cancer screening. So the women had some experience in trying to get information about the prostate cancer. When you look at the men, I would like to just draw your attention to where when we talk about had someone went to the doctor's office with them and was the person present, those numbers were low. So if we put those numbers with the numbers that we had previously for the women that were knowledgeable and they accompany these men who don't have anyone, then it should balance out for a good discussion. So my significant findings were women were knowledgeable about prostate cancer and prostate cancer screening pre-educational intervention. And the women had interest. It showed that they have interest in their men's health. The men had significant increase in knowledge after the post-educational intervention. And also there was an increase in men's attitude about prostate cancer and prostate cancer screening. The limitations of the study is that it was a small sample size. It was convenient sampling. And also the quantitative design of the study did not allow for open-ended questions or discussion to explore how women shared this knowledge of prostate cancer and prostate cancer screening with their male partners. Future studies, definitely a larger study sample. We need to evaluate the strategies of healthcare providers' assessment tools regarding prostate cancer and prostate cancer screening. We need to also take a look at developing strategies to increase women's participation and involvement in making the appointments and accompanying them to the doctor's visits or healthcare provider visits. Explore how women share their knowledge of prostate cancer and prostate cancer screening with their male partners, and further investigate reasoning for low prostate cancer screening among African American men with the lower socioeconomic statuses. We saw most of these men were educated, they had insurance, but we need to look at the men with lower socioeconomic status. And then follow up with the study that I did to see if there were any behavior changes amongst that group. Implications for clinical practice. Of course, we want to include the significant female partner. We want to encourage partnership between the African American men and their female significant. And we also want to encourage partnership with preventive care measures. Like going to the doctor's office with them and making the appointments, talking with them about it. And then we need to educate policymakers. We looked at those national guidelines and the differences in the recommendations, and also patient advocacy groups. We need to educate them about these data about the prostate cancer risk, and also provide education and assessment tools that provide both the male and female perspective to give ideas on prostate cancer and prostate cancer screening to healthcare providers. So findings from this study did suggest that educating African American men about prostate cancer and prostate cancer screening with their significant female partner may increase their intent for prostate cancer screening. Prostate cancer awareness may reduce mortality rates in African American men. Encourage healthcare providers to discuss, these are things that we should take away from this. Encourage healthcare providers to discuss risk of prostate cancer and the benefits of prostate cancer with men aged 45 to 70 and their significant partner. And also disseminate findings from this study to engage nurse practitioners and physician collaboration to improve outcomes in prostate cancer screening. My dissemination, I did send in a query letter to SUNA, which is the Society of Urological Nursing Association, which is a journal it's a urological journal for my proposed publication, and I did receive a letter of interest.
Good job.
And I plan to submit a poster abstract to SUNA as well for their 2014 fall conference. And also, I got some information about the Association of Black Nursing Faculty having a conference, and I would like to submit an abstract to them as well.
Good job.
So, to reintroduce my committee, I would like to thank Jean Gash, Dr. Gash, my chairperson, for, even though we went, I just thought she was just picking on me. She really was helping me, and I have to see that I learned a lot, I came a long way, and I do appreciate you. I really do.
I appreciate you too.
She is the chairperson for my committee. And Dr. Patricia Ruin, who has been with me throughout my master's program in here. And she's always been there. She sat with me outside of school, and she's just been a big encourager. Excuse me, I'm sorry, my bad. And Dr. Renee McCune. She just took on a brand new position here of prior. And she has taken out time and spent time with me, and she did the health literacy for my flyers that I had to put out to make sure that they were properly written so that people understood exactly what I was talking about. And I do appreciate all of you for everything that you've done. I really do, and I want to applaud you. I do thank God for everything that He's taken me through. He is my shepherd, and I praise Him for everything, and I thank Him for bringing me this far, because I couldn't do it without Him. Also, I like to acknowledge the churches that allowed me to come in and do my studies. And that was Pastor Dana Darby at New Jerusalem Missionary Baptist Church, and Pastor Franklin Garrison at Grace Temple Church of God in Christ, and Pastor Stephen Campbell at Bethesda Temple. And of course, I have to thank my family. But I have to say my husband has been very, very supportive. He's watched me cry, he's watched me get married, he's missed meals, he's done a lot of things. He's still here. And my brother has been encouraging to me, and he's been obedient and did his prostate cancer screening. My daughter has been very, very supportive too, and I'm so proud of her. She's a nursing student at Montgomery right now.
Thank you.
My son couldn't be here. I tell you, he has been my rock. He has edited papers. He's very good with edited PowerPoints. I mean, he's too young for the prostate cancer screening, but he knows all about it. And of course, my Chi Phi sorority sisters, and there's several of them, and Carmen is among them, and there's a lot of them, and they were very helpful to me. And all my classmates, I just love you guys for being here. I feel like we're back in class. I know. And all my participants. So I hope after I did all this, I passed. But anyway.
I know that's right. Good job.
Oh, you know, I did. Questions? And my sister Mary Ellen, I want to say thank you because she looked at my papers too. She has been a rock to me too, very encouraging. I love her. And I've only been working with her for about 8 months, but I'm telling you, she is the best person you ever want to work with. Bayardi, you know you know how I feel about you. Dr. Bayardi, and we always have to tell that same story, but I have to tell it, is that when I went to Dr. Bayardi, my nurse practitioner program, I really didn't want to do that because I felt like it was going to take too long and I was too old. Like, Dr. Bayardi, I'm going to be 40 years old when I finish this. And she said, well, look at it this way. You're going to be 40 years old anyway. It brought a lot of light to me, and I appreciate you for all your encouragement as well. I really do. So, I'm done. Any questions? Oh, yeah, Dr. Bayardi?
I'm going to be nice. If you were to think about everything you learned in the study and think about Cabrini Clinic and where you practice, how might you bring this knowledge to the clinic? Because we don't do a lot of prostate cancer
I'm
screening.
always screening them and asking them about their prostate cancer screening, if they've had it, if they know about it. I do educate the men that's in that age range that come in. And actually, I've had them be receptive to it. And I've had them ask me. I had a guy just come in last week and told me that he wanted to know what his PSA was. He said his father had died at age 65. And that his sister, it just all worked out perfectly. He said his sister is always on him. Like, that's a significant person. And then he was interested. So I have been, but I would like to incorporate something at the clinic where we are screening them, because I know that everybody have their differences on the recommendations, because I've had that conversation with some of the doctors. But then you have to look at, these are high-risk individuals, and you can't always go by that. So, yeah. Yeah. Hi, Catherine. Yes.
Alicia, I wanted to ask you, did you find in the literature outside of urology clinics that regular clinics were actually doing any prostate cancer screening or not?
Outside of that, do they?
Outside of urology,
In the literature, it was few healthcare providers that did. Few. Yeah.
I thought that.
And
even talking to, because you could see that they hadn't heard of, they had heard about it, but they hadn't really discussed it with them.
Yes, yeah.
Not a question, just a comment, coming from family practice, you did a wonderful job. But I can tell you some of the barriers, when you think about it, the way you presented it, it was fantastic, because sometimes, when you ask a patient, you're over 40, it's time to think about what you need to do. And everyone's like, well, let me think about it. Let me come back. Let me prepare. And even for that gentleman who doesn't have a significant other, per se, girlfriend or wife, if we can encourage them to bring, a family member with them that can kind of talk to them about the importance of it. That's something to think about. That's valuable.
That's a good point. Yeah.
Thank you.
Is it any resources out there available? Because I know with the breast cancer screening, they have the BCCP. So once you do the screening for those men, you find that they have the cancer, is it any resources where they can be treated?
Yes, there is. There's, we have a sheet where they would be, I would be able to give you something, to give you some information. I think where Dr. Gash is. Yeah,
Physicians who can. Okay, cool. Yeah.
Yeah, because like I had did a business plan with Pat looking at, taking a mobile unit out and trying to screen men. We talked about doing it in one of the industries, but I wanted to go out into the community, and that was something we had to look at, is once we found it out, what were we gonna do with them? You know?
That's the thing. And with the physicians who care, do they take a certain amount of men, or do you refer everybody to them?
They probably have some funding.
There's a program through St. John's, and that's where the physicians who care work out of. And it's a certain amount in their practice because they can't take all. They donate their time.
Okay.
St. John's donate the OR and the anesthesia, and then they donate their surgical time.
Okay.
So you mean for the surgery, or?
I'm just saying for treatment in general.
Because I know even at Cabrini Clinic, we also have affiliation with Henry Ford where we can send people out for referrals as well. Yeah. And Lori, I'm sorry.
Oh, no, it was amazing, really good. It was nice to see it come to fruition.
Yes,
Talking
yes.
about these things every week, Priscilla.
I know you heard.
Remember? Yeah. You know, had our thing, didn't we? When you were talking about the health belief model, it brought back memories of theory and my favorite class. The two words that struck me were motivation and confidence. And looking at your sample, you had a lot of those gentlemen were already educated and had health insurance and stuff like that. And had you run across anything about health belief models in the population that you're most concerned about? The ones that you see at Cabrini that may not have, I just wonder what we could do to get them to that, bring the female partner in. But what else is there, do you think?
Well, I think the health belief model itself, the theory itself, once you get them to buy in and understand the seriousness of it, that's what I have been doing with the men at Cabrini. And it seemed to make a difference.
Right, and it seems like it needs to really come from the provider to say,
Exactly.
this is serious.
And it has to start with that discussion.
And you're African American, so therefore
Exactly.
you really have to think about it.
Exactly. That's right. Yes.
Okay, that was really great.
Thank you.
Any other questions?
You did a great job.
Okay, to step outside for a few minutes.